So if you look at the imaging modalities in the shoulders, there are predominantly 4 modalities. You know, we have the shoulder X-rays. I mean, you have the X-rays, you have the ultrasound, CT scan, and MRIs, and each one of them comes with some kind of a, you know, advantages and disadvantage. Now, in the era when everybody drops into the OPD with the, you know, the throwing the MRI on the face that my MRI is done, it is often possible that people do miss the X-rays. And they think once the MRI is done, the X-rays or CT scan may not be required. No, that's not true. Yes, MRI is helpful to diagnose quite a lot of condition, but those conditions can be very simply diagnosed with the help of simple shoulder X-ray. You don't actually need the MRI to diagnose that. So let's start with the simple shoulder X-ray. This is how actually a simple shoulder X-ray looks like. Normally, when we order a simple shoulder X-ray, there are many views you can ask. 3 views are very common. You have the AP view, axillary view, outlet view, and then you've got a lot of special views. So we'll talk about the special views a bit later. Now, let's see what do we see in this AP view. So AP views are basically of the shoulder joint to see your common bones like clavicle. You can see the acromion. You can see this head of the humerus. You can see this joint. You can see the part of the coracoid, scapula. That's all. This is the normal AP view talks about. Now there's a discussion about should it be just a general AP view or should it be true AP view? So this particular X-ray, if you see, is a true AP view because here the anterior cortical, the cortical line of anterior and posterior, they're perfectly matched. And then you have got the normal space. Now, why it is important, if there's a blurring of this line, this may indicate that there has been some kind of a erosion of the anterior glenoid wall, which is seen in the recurrent dislocation of the shoulder. Now, this view also helps you in figuring out what's happening to the AC joint, what is happening to the acromion. If there's a lateral osteophyte, which you see here, can be very, very nicely seen. And all these things are extremely difficult to interpret on an MRI. Even the experienced radiologists, sometimes they miss it out. You can look at the arthritis, you can look at the tuberosity, smallest of the avulsion can be actually picked up with this. If there's a cyst in the head of the humerus, no other investigation can show you a beautiful cyst other than it's just a simple X-ray. Now moving on from here in this, if you have to say the arthritis, look at this AC joint arthritis. Now this patient has got AC joint arthritis. Now one caution, often the radiologist in the MRI or sometimes on the plain X-ray may report the arthritis, but that does not necessarily mean that it has to be treated because as Ashish said, unless and until. Am I audible?
Yes, sir, you're audible. Go ahead.
Hello.
Yes, sir, audible.
Okay. So as okay, thank you. So as Ashish very rightly was showing this cross chest reduction test. So unless and until patient has got a clinical tenderness over this point and the cross chest reduction is positive, and along with that you have got some radiological feature. If you look at it otherwise, please do not treat the radiological arthritis of the AC joint because that is often a age-related change and that may not be contributing to any kind of the patient symptomatology. Moving to the next joint, that is the acromiohumeral joint. Now this patient just came to me, this X-ray, especially this X-ray came to me about, I think a month back with the, with being diagnosed as frozen shoulder. And as Ashish was telling that not every painful shoulder is a frozen shoulder. And he told me that my pain has been there for 3 to 4 years. Now, no frozen shoulder can go on for 4 years. Yeah, some little pain can be there in diabetics, but by and large, all the frozen shoulder, they tend to resolve by 2, 2.5, maximum 3 years. So he said, I have got an MRI. I said, I don't need your MRI. I just need one simple shoulder X-ray. And this is what the X-ray shows. Look at the huge osteophyte at the lower end of the humerus. Look at this joint space reduction. You can also see some small osteo, the subchondral cyst, the typical features of the arthritis of any joint. So this is how a simple shoulder plain AP X-ray can give you such valuable information. If it's a case of trauma, you can see a lot of fracture lines here and there. You can see the AC joint dislocation, but We're not discussing the trauma too much here. Moving on to this another set of very important X-ray, which we often ask in a painful shoulder. Now, if you look at the painful shoulder, there is only one condition by and large, non-traumatic, non-septic, which is very painful. And it is extremely painful. Patient will say that it has been painful for last 3 to 4 days, terribly painful. Doctors, I can't sleep. Most of the painful conditions in shoulder, they'll give you a history of, let's say, month, 6 weeks or more or so. But if somebody tells you that my pain has been there since yesterday, day before yesterday, 1 week maximum, and it is very painful, and there's no history of trauma, you are not suspecting any infection, then there's only one diagnosis which is there in the possible diagnosis in the shoulder, that is the calcific tendinitis. Now again, a lot of people actually ask for MRI. Now it may be hard to pick up a calcification on MRI, but it's very easy to pick up the larger calcification. You can see here on the plain X-ray, and even a smaller calcification. Can you see this? Now this is the simplest investigation which will pick up. Now the only problem with this X-ray is once you get a suspecting a calcification, I'm sorry, I don't have the X-ray at the moment. Do not ask only AP. Also ask the axillary view, which I'll show in the next view how it is possible. Because this will not tell you where this calcification is. It anterior or is it posterior? Where exactly is it? In axillary view, you can actually figure out in which part of the subscap or supraspinatus or infraspinatus it is, because it tells you where in location it is. So in calcific tendinitis, the investigation of choice for me to start with is always and always the shoulder X-ray, plain X-ray. Yes, if I have a doubt about the cuff tear, which is coexisting, I'll go to the MRI later. Another important thing is acromiohumeral interval. Now, what is this acromiohumeral interval? Now, if you look at a normal plain shoulder X-ray, the distance between the undersurface of acromion and the top of the humerus here is known as the acromiohumeral interval. And in normal population, it is about 8 to 14 mm. Now, this is almost akin to the distance between the radial stellate process and the ulnar stellate process. So 8 to 14 mm, that's a normal one. Now, who maintains this space? As Ashish was telling, we were discussing this, that the job of the cuff is actually to centralize the head of the humerus and the center of the glenoid, somewhere here. If the cuff is gone, especially the infraspinatus, the cuff starts migrating upwards, the head of the humerus. And this is what you get. You see this is an X-ray where there is no space. When the acromiohumeral interval is less than 6 millimeter, it implies that supra is gone definitely, but infra is also gone. So if it is more than 6 millimeter or 8 millimeter, it doesn't say that the supra is not gone. So the distance less than 6 millimeter implies that infra is gone. Okay, but a word of caution, it does not signify the repairability. The cuff may still be repairable. So don't think that if the distance is something like this is not repairable. It is very well repairable, often repairable. Sometimes, yes, you may not be able to repair supraspinatus, fair enough. You can come back with the repair of the subscap and the infra also. Moving on to the axillary view. Now, axillary view traditionally is required for dislocations. And this is one view which is often missed in a prior practice. They don't do the axillary view after the proximal humerus fracture fixation. It's extremely important on the table and off the table to where you can see where are you actually the screw. But the calcification here will tell you whether the calcification is actually anteriorly located or whether it is posteriorly located or somewhere here. And this helps you in understanding their pain pattern, or the radiologist will be, find where he has to insert the needle. So this is in general what all X-rays we do. Another one is the outlet view. So we had AP view, axillary view, and now comes an outlet view. What's an outlet view? This is something like a scapular VY view. Here, the single most important reason why a shoulder surgeon does is to know the undersurface of acromion, like this. So there are 3 types. We all know Bigliani type 1, type 2, and type 3. So this is the Bigliani type. This is the simple, probably just a little curvature here. So maybe it is 2. If it is 3, something like this here, something like this, you can see here. So the curvature suddenly becomes like this. Okay. So this could be 2 with a hook. Why it is important? Because only in these patients, when you're doing your cuff repair, you would like to do the acromioplasty. Traditional acromioplasty, wherein every patient was undergoing the acromioplasty, is no more possibly recommended, because people think that it may not be one of the culprit. But when you find such a huge acromion here, which is going down like this, possibly it is impinging upon to the cuff, and that's the one which you would like to remove and shave it off. Moving on to special views, a lot of special views have been described, especially for the recurrent dislocations, to know the Hill Sachs lesion, striker notch view, West Point, Garth, and off late the latest was the Bernocchio's view. Unfortunately, most of them are sensitive, specific, all that is fine, but the making a decision based just on the X-rays, the clinicians, especially the shoulder surgeons, are very, very, apprehensive. Nobody makes a decision whether I would like to do the Latarjet surgery or a simple Bankart repair based upon this, or a remplissage. So we have moved on by and large from the special view, because decision making is not affected by the special view. So I mean, I have stopped doing my personal practice for last 8 to 10 years. I just don't do any of these, except, yes, axillary review, continue it. The rest of the things is now gone. It's all based upon the CT scan. The next very important investigation, an extremely handful investigation, is the ultrasound. How you can use the ultrasound is all the soft tissues around the shoulder and not in the shoulder. So if you're suspecting, let's say, labral tear, then that's not the one. Synovitis, something which is inside the joint, ultrasound may not be a great investigation, but anything which is outside, let's say the cervical bursa, the rotator cuff, the biceps, the calcification, or any other soft tissue tumor, you're suspecting a pus in the, the soft tissue planes, this is another fantastic investigation. But you need to have a good radiologist. Without a good radiologist, the ultrasound is not really good. Ashish, you are really, you're really blessed. You have your own personal experience, and you've got, your own wife doing fantastic ultrasound. So next is, and when we do the repairs, the MRI has got a problem. Like MRI can throw these, these artifacts when you want to check the repair. But the ultrasound can really, and the sensitivity and specificity in the hands of a good sonologist is almost equivalent to the MRI in the post-cuff repair situations. And procedures also, you want to do any procedures, especially the ultrasound guided injections, like in our place, we are just doing all the procedures, all intraarticular injections, or the calcific tendinitis barbotage with the help of ultrasound only. Very big advantage is no claustrophobia. It's very cheap, and the important thing is you can check the dynamicity of the cuff, especially whether there's an impingement or not, which is not possible on a MRI. This is the favorite investigation, lady love for everybody. Everybody wants to do MRI before you talk to patient, before you clinically examine. And sometimes the patient will also throw their investigation right in front of our face, and they'll say, I've got an MRI. Now, Ashish, all of us practice this, and Ashish was very categorical about this, that please do not see the MRI or see the CT scan or see the X-ray unless you have done your basic history taking and examination. Now, MRI, like any other part of the musculoskeletal system, it is fantastic for soft tissue imaging. You want to see the soft tissues, see the word soft tissues, not the bones. MRI is the best investigation. So labral region, because labrum is inside where the penetration of ultrasound is not possible, so it is fantastic for labral regions. The cuff tear, whether there's a tear in the cuff, whether there's an atrophy, fatty infiltration. I'll not go into much detail, but all that can be very well seen. If there's a bone contusion, bone cyst, how's the cuff healing, all that can be picked up with the MRI. Now, one thing which is difficult with the ultrasound is the fatty infiltration and atrophy, especially if you want to assess the same thing on the subscap side. It is easy for supra, it is easy for infra, but to assess the subscap on the ultrasound, because it is behind the chest wall, inside of the chest wall, it is not easy. This is the one which usually decides the probably whether you want to treat or not, and how's going to be the outcome of the outcome after your repair. If the fatty infiltration is, let's say, 3+ or 4 in the MRI Gottlieb grading, then you know that the prognosis, even if you do the repair, even if the repair works fantastically, Since the muscle has lost the power, it is all replaced by the fibrous tissue and fatty tissues, and it has lost the bulk. In future, it will not generate the enough power. So patient may have some reasonable pain relief and all, but his function will not be completely restored. So this is one investigation. MRI is extremely useful. And if you correlate with the X-ray, where there's a huge, where there's a hardly any acromiohumeral interval. So if I know that this looks like a chronic tear of the cuff with the acromiohumeral interval very low, let's say it's just about 3 or 4 millimeter, and patient says my history goes for 2 to 3 years, it is not an acute traumatic tear. It is a history which is going on for 3-4 years. Then I will not touch him. I will first take him and get his MRI done, possibly because ultrasonography, you can't really trust this sonologist. Do the MRI and check how is the fatty infiltration and the cuff atrophy, and then proceed from that point whether you want to really operate or you want to give a guarded prognosis before the rotator cuff repair. Problem is claustrophobia, especially some of the elderly people find it difficult to lie down inside. Asthmatics, cost is always an issue. Now, bone assessment. So what kind of bone, bone assessment we are talking about? Now, this is one case which we'll discuss in just due course of time. A lot of us see the recurrent dislocation, primary or recurrent dislocation of the shoulder. Now, patients go to a general orthopedic surgeon who would do his due diligence. He will reduce the shoulder. He will get the X-ray done. And X-ray shows a reduced dislocation. Then after 2 to 3 weeks, patient comes back. He says, all is well. Can I proceed? He says, yes, okay, let's do an MRI. Now, MRI will show a labral tear. Now, MRI will just show you the labral tear. It is often very difficult to figure out what has happened to the bone and MRI. Some cuts, yes, not always. CT scan is the one which tells you what's going on with the bone, because today the management of recurrent dislocation is predominantly based upon one thing, that is the bone loss. If you have a very severe bone loss in the anterior aspect, that means that the bone is lost almost more than 25%, or let me give you the lower limit, 20% onwards, then just the mere bank cut repair may not suffice. In that case, you might have to do the bony procedure, something like a Letarge or the iliac crest grafting. Same thing goes here at the Hill Sachs area, where you have got the attachment of the infraspinatus attached here. You can see here a small dent. This dent area is actually the Hill Sachs index. Now this can also be very, very nicely seen on a CT scan. It gives you an idea that how wide is my Hill Sachs index, and is it going to give me is this Hill Sachs lesion is on track or off track? All that can be actually assessed with the help of the CT scan. So it is important for the recurrent dislocation. In fact, in primary also, because you can also figure out the bony bank cut. I'll show you one CT scan. And if you're planning for your total or reverse shoulder, the bone assessment in osteoarthritis or rheumatoid shoulder. So look at this patient who has the other side normal, but this side is having a bony bank cut. You can see a bony bank cut here. Now this is almost, the remaining bone is something like close to 15%. With this loss, this is often very difficult to pick up on the MRI. And this is what is end-on view. We call it as end-on view. End-on view gives you the categorical picture whether he is fit for the arthroscopic bank cut repair or the Letarge. That's why this debate ends here. Most of the time, it is very easy to figure out. And this, even if you're not calculating, you don't have a software, still you can actually see the end-on view of the glenoid, and you can figure out, okay, how much is the loss. So if you see the CT scan end-on view and you see a straight profile, something like this, a straight profile, then it is close to 15%. If your loss is concave, if the glenoid has become something like this, then the losses are close to 20 to 25% or more. In this case, you have to plan only the bony procedure. You can't go inside without having a CT scan, and then on table, when you don't have a consent, you can't say, okay, I'm going to change my plan. It's not only the plan, the position, everything changes. So in dislocations today, it is prudent to have the CT scan. Some centers do give a MRI and CT combination. That's up to you and them to decide. In the osteoarthritis shoulder, the type of glenoid, whether it is A, B, or B1, B2, whatever it is, And along with the cyst, it helps you in a lot of planning, how you should plan, where are you going to place your prosthesis, or where is going to be the center, whether you're going to graft it or not. The situation of the cyst, you can see multiple cysts here. So this is in general the investigations we perform in the, I mean, these are only 4 investigations classically done: X-rays, CT scan, MRI, and ultrasound. So I'll just say in general, the first investigation, by and large, without fail, should be a plain X-ray of the shoulder. Now, if you suspect that the patient has got a cuff pathology, please include outlet view. Otherwise, a simple, plain, true AP is enough. Axillary view in general doesn't give me much information unless and until I'm doing a assessment of my proximal humerus fracture or a logged posterior dislocation. Now, if I'm suspecting a soft tissue pathology, something like biceps tendinitis, cuff tears, bursitis, it's being taught that it is the capsule which is stiff and tight, or there's a synovial thickening and all, but in fact it is the coracohumeral ligament. And Ashish has been doing some study of it where he's been injecting, the injections into the CHL ligament. So it's classically the CHL. So you can actually measure the CHL thickness on an ultrasound. So if I have a soft tissue pathology in my mind, I'll go with the X-ray followed by the ultrasound. If I have made a perfect diagnosis, I know that it's a cuff tear, it's a cuff tear of short duration, and I'm not suspecting a great atrophy or infiltration, I may proceed with my surgery. But if I feel that no, this is an old cuff tear, there may be something else to it, or let's say it's a slap tear. Now, if you have followed the Ashish talk, slap, the classic slap type 2, which was described by Snyder, about 20 years back, is hardly seen. Most of the time, it is actually the posterior superior labral tear. Sometimes there can be an associated cyst with that. And if you have not seen, you're going to miss it. If you don't go and decompress that cyst, which is sitting right over the suprascapular nerve, you're going to miss it. So never, ever, ever operate a patient who's got a labral tear within just an X-ray. You have to have, especially the slap tears and posterior labral tear. Anterior labral tear, yes, if there's no clinical suspicion of the muscle wasting, or let's say the weakness in external rotation, and you know that there may not be any associated spinal or cyst, you can probably go ahead with the surgery. But if you're suspecting a posterior labral tear, posterior superior labral tear, or a slap tear, you need to have the MRI. Now coming to the CT scan, so dislocations, fractures, or a osteoarthritis, I think one of the best investigation is always to have the CT scan. If you have a patient with osteoarthritis, primary osteoarthritis, but there is a huge cuff atrophy and there's a fatty infiltration, then again, in those cases, you have to combine with MRI, because in those cases, mere CT scan will not tell you what's happening to your cuff. You do a primary shoulder replacement in a cuff which is atrophied, which is fatty infiltrated, there's a partial tear, it will fail in few months time. Then are you going to revise with reverse? So most of these investigation, you just have to follow some kind of algorithm in your brain, and then it will tell you, okay, what is most required for this particular patient.